All right. Hello and welcome, everyone. Thank you for joining us for the Importance of Lived Experience in a Recovery-Oriented System of Care webinar. Whether it's morning, afternoon, or evening, where you are, your presence here matters. I'm John Picard from Faces and Voices of Recovery, and I'm honored to moderate today's event. This series is proudly hosted by the Colombo Plan, the International Society for Substance Use Professionals, ISSUP, Faces and Voices of Recovery, and the Global Recovery Network, GRN. These organizations are working together to strengthen recovery systems worldwide. While we are waiting for a few more of us to join, I will begin by saying a little more about ISSUP, a membership organization for the global substance use workforce with over 35,000 members worldwide. It is an international network that unites, connects, and shares knowledge across the substance use prevention, harm reduction, treatment, and recovery support workforce. ISSUP's global mission is to make the work of members as impactful, accessible, and effective as possible. They do this by making it easier to discover and share evidence-based knowledge, best practice, training, and networking opportunities. If you've not done so already, please head over to the ISSUP's website, issup.net. That's ISSUP.net, where you will find information on how to sign up for that free membership. The website also has a wealth of resources and publications for you to enjoy. You can also watch recordings of past webinars and see future events listings. I'd like to thank the ISSUP staff for providing technical support for this webinar. For those of you who don't know, this is a 6-part series taking place every other Tuesday, concluding on September 30th, International Recovery Day. Each phase of the series focuses on building knowledge and capacity across 3 areas: core foundations of recovery, advocacy 101, and leadership development. Today's session concludes the core foundations phase. So today, we journey into the importance of lived experience in a recovery-oriented system of care with Julia Ojeda. A very warm welcome to you, and it's a great pleasure to have you with us today, Julia. For 30 plus years, Julia has been providing solution-based leadership training and consultation in the education, healthcare, and social services sectors as an experienced facilitator, trainer, coach, networker, and change agent. Her work is rooted in an equitable, people-centered, integrated approach to progressive change, system-wide reform, strategic management, and organizational development. From 2013 to 2023, she managed peer recovery support services for the Massachusetts Department of Public Health, the Bureau of Substance Addiction Services, BSAS. She was instrumental in the growth of peer recovery support centers in Massachusetts, which grew from 5 in 2023 to what is now 39 in 2024. She created the first statewide peer recovery education program with 12 curriculums and 19 facilitators in recovery, where over 7,000 Massachusetts residents participated. She championed the first deaf, hard of hearing peer recovery coach team in the state, possibly the country, and managed MORE, which is the Massachusetts Organization for Addiction Recovery, for 10 years. As a person in sustained long-term recovery and an active member of the recovery community, including the National Habla España Recovery Network, she is champion for the peer recovery workforce movement and the development of recovery-oriented systems of care, promoting prevention, intervention, and treatment efforts locally and nationally. Now, before we get started, I'd like to go over a few items so you know how to participate in today's event. Today's session is in English with interpretation available in Spanish. Please check the link in the chat to access the Spanish interpretation. This session will be recorded and you will receive the slides, video, and resources via email after the session. You will also have the opportunity to submit text questions to our presenters by typing your questions into the questions pane of the webinar interface on your screen. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. As a person myself in long-term recovery and having been in some of the same recovery spaces as Julia, I'm excited to hand over the webinar to our esteemed presenter. Julia, the floor is yours.
Thank you so much, Jonathan. So appreciate all that you shared and all the work that everyone is doing. Before I start the presentation, I'd like to, first of all, welcome everyone. And I'd like to start with my story. As mentioned, I'm the founder of RIO, Recovery Inspired Opportunities, and which has worked with nonprofits for many years around building capacity and sustainability to organizations. So a little bit about me. I was born Puerto Rican parents in Harlem, New York City. And my dad, actually, Orlando, in World War II, in the Korean War and World War II. He became um, in basically the border of Canada, 12 hours from New York City. Trying to at the age of 17, I was locked up for a pinch use supervision, court mandated to a 24-hour city or within the country. And
Julia, your sound, your audio is dropping off quite a bit. I'm not sure why, but we're having trouble hearing you. I would say try to point your speech towards your computer more than yeah. Hi,
okay.
Yep,
Okay.
that sounds better.
Okay. Is that better?
Yes, it is. Awesome.
Okay. Thank you. Should I bring up the volume at all, or is the volume okay?
The volume's good. I think just make sure to point your voice in the direction of your computer, I think, is working well. Yep.
Okay, great. All right. You got it. Thank you so much. So this picture actually shows that I was actually advocating for the treatment center that I was presently living at. And with these are U.S. aides from Europe and the United States, including the mayor of New York City at the time, and basically sharing, that there are teens that are addicted and that needed treatment. And so this obviously started a long, long time ago, and that's my baby Raquel, who's now no longer a baby, and that's where we started. Um, and even as a result of that, in 1984, I actually overdosed or seizured while smoking freebase cocaine. While going to graduate school for my master's, I was brought back to life by an angel. Recovery found me. And in 1986, I completed my master's degree in education, and for the next 25 years worked with nonprofits on organizational development work, specializing in team building, diversity, and I did a lot of staff planning retreats. I got involved with systemic change and started working 3 years facilitating national community programs on prevention and 3 years of national work to close the achievement gap in city public schools throughout the country. I then understood systemic work and how difficult it was. In 2013, I was approached and recruited for a leadership role to manage and run the Massachusetts State Department of Public Health Bureau of Substance Addiction Services, their program, their Recovery Support Services program, and to be the manager of that program. At the time, it consisted of 5 new peer recovery support centers, and it And my goal was to have one in every single town in the state of Massachusetts. I championed the first recovery education program during the opioid epidemic, which was not an easy thing to do for the state. And I hired and trained 27 diverse facilitators, all in recovery, to provide 15 curricula that were related to recovery. And as a result, I was also able to create the first deaf and hard of hearing peer recovery coach team, I believe, in the country. It was a dream job in a political bureaucracy that strained even the best of us. I'm committed to recovery-oriented systems of care, building a strong peer workforce, and advancing better systems, especially in communities of color where I have lived and worked all my life. It is my heart and it is my lens. Anyone that has ever accomplished anything great knows that it takes a village and very special people to make it happen. So shout out to Jen, Marion, Iliana, Danielle, Karen, Tulani, and all of my recovery trainers. Thank you. Now, this and many other experiences have made me the person I am today, an advocate for ROSC, recovery-oriented systems of care. And with that, I'd like to start my presentation. So, please hang in there with me. This is my first time on GoToMeeting. I'm a Zoom champion, but GoToMeeting is my first. I'm a virgin on this one. So, in starting my presentation, also the power of lived experience and how it has impacted and or impacting ROSC. And so I believe that a better system is possible. I want to thank ISSUP and Faces and Voices of Recovery for giving me the opportunity and the privilege of sharing with you today. If any of you had been following or engaged in the AI technological revolution, feeding it requires a huge energy supply. Blocks and blocks and blocks of data centers. And for us, it will require time, energy, and commitment to learn and use it ethically. This is the same thing that is required for ROSC. As we explore the concept of recovery-oriented systems of care, I invite you to reflect on the immense potential that lies within our communities when people with lived experience, compassion, and shared vision for recovery come together. Shown me that real, but it demands sustained effort, courageous leadership, and a willingness to challenge the status quo or present circumstances. As we move forward in the presentation, I encourage you to consider what role you can play in advancing ROSC within your own sphere of influence. Whether a policymaker, an advocate, a peer, your commitment matters. Let's channel even a fraction of the energy that fuels technological revolutions into a revolution of healing, inclusion, and possibility. So speaking, we are living in a world of uncertainty. For those of us who are working in nonprofits throughout the world, where our fundamental values are being threatened, there are budgetary cuts happening everywhere. Our staff, family, friends are being laid off from jobs that we thought they would be in, and they thought they would be in for many more years. We are confronting real threats. And unfortunately, our future doesn't look certain at all. There are adverse impacts on everyone, every individual in community, whether you have been laid off or not, whether you have family members. This is happening every. It's something to actually stop and think about. But the truth is this: as leaders within organizations, we can't be thinking of systems right now. We have to keep our organizations together. Well, I'd like to challenge you on that and say that, at times like these, I think we need to think differently and we need to work together, not alone. At times like these, we need our leaders. At times like these, we need to be strategic. We need to stay true to our values and to our vision and have faith in ourselves that we have solutions within us and that ROSC can actually be incredibly helpful to move us forward. I wanted to share a little bit about the history of the recovery movement. And in here, it's just a few, this is sort of a hodgepodge of it. Just want to share that in 2005, 100 recovery advocates were brought together in Washington, D.C. to, really talk about recovery for the first time in a formal way. Our goals were centered on developing recovery-oriented systems of care, and this is where the formation of the National that Advocacy Organization Faces and Voices of Recovery was born. This is also where we launched the new recovery advocacy movement. If you'll also see here our guru for recovery, Bill White. And in the resources that I'm offering you at the very end of the presentation, you'll have his YouTube channel, you'll have his access to all of his papers and his writings, his monographs. He has been such an influence for all of us who are in recovery. I just cannot talk highly about Bill in any way, that it just has moved us to a whole different world. For those of us who are in recovery, we are no longer anonymous as a result of the efforts of all of these people. And in September, throughout the entire country, September, in the entire country of the United States, we celebrate recovery. And there are massive marches throughout every city and town in the United States, basically putting a face to the voice of recovery. I would be remiss to not add CCAR here, because CCAR actually, the Connecticut Community of Connecticut Addiction Recovery training that they provided, they actually are the organization that created the Peer Recovery Coach Academy, the 5-day training that actually started us all working as peers throughout the country. And now there are thousands and thousands of people who have been trained, and that includes not just the United States, but also throughout other parts of the world. Now, who has been driving this transformative change? These are our originators, our creators, and our champions. Dr. Arthur Evans and Dr. Ijoma Akara were the first ones to actually take the city of Philadelphia, and the mental health and addictions world, and bring them together and really start working on and moving forward in systemic change in relationship to ROSC. The others are key people, which I would suggest to you that you look up within the internet and see what their contributions have been to the world of ROSC. So I'd like you to take a moment, if you have a paper and pencil or pen, and just jot down, what does recovery mean to you? Think about it, whatever comes to your mind. What does recovery mean to you? A couple of words, a sentence or two. And I'd like you to, in thinking about that and jotting it down quickly, I'd like you to then compare to what I'm going to share with you. So for us, it's more than reduction or elimination of substance use. There are a lot of places that think, well, once they stop using, that's the goal, isn't it? That's the end. But we think that's not the end. It's only the beginning. Jonathan?
Yeah. Just again, and I know, like, I'm a very talkative with my hands and moving all around kind of a person. Would just try to be intentional about kind of like talking directly into your computer screen, and not trying to move all around, because you're on the means pulling it out again.
Really difficult for me. Okay. So this is about living a full, meaningful life in one's own community. So this is what our goal is truly. Now, in actually researching ROSC on the internet, in 30 minutes, I came up with 12 different models and frameworks, definitions, different definitions for ROSC. Well, the truth is that ROSC is not a model, but as a result of years of misunderstandings, misinterpretations, ROSC has, for many people, turned into many different things. And I think it's important to understand that the greatest challenge of implementation of ROSC is the lack of conceptual clarity. And so I'm going to try really hard today to help folks understand that. Dr. Ijoma Atara has been my mentor when it comes to ROSC, and she said the confusion is that people jump to practice change and trying to change practices before they put in the work of creating shared understanding and shared vision for the future of their system community. Dr. Achara had devoted her entire career to ROSC, and she, as I mentioned before, began with the Philadelphia ROSC Initiative alongside Dr. Evans. So she's absolutely spectacular. She is also in the resources that you will see. So this is a lot of food for thought. ROSC is a system with many components. So I'm sitting in a meeting and I'm presenting about ROSC, and folks say to me, a person jumps up, this man says, raises his hand and says, this really doesn't have anything. And I said, why is that? He said, because we're prevention. And then another person kind of agrees with him and says, yeah, this has nothing to do with us. We're treatment. And because of the word recovery, for some reason, be it the way things have been done in the past, it's it's really important to understand that this is all ROC. This is all ROC, mental health, trauma, community coalitions. These are components of ROC. This is not a ROC. So initially, mental health and addiction were both involved and encompassed in a ROSC. However, changes in circumstances led to it being associated primarily with addiction, which sparks ongoing misunderstandings to where many of us are today, where various definitions are circulated as a result. I'm going to share with you just some of the principles and values. In most ROSC definitions, you'll see comprehensive care, people centered and self directed, that we're peer or integrated. We're integrating peers into all of our organizations. We believe in multiple pathways of recovery. We work on community engagement and empowerment, and we focus on long term recovery. These are the tenets of ROSC, our main principles. There are others, and also how respect is incredibly important, especially to families and those who have lived experience. Ownership, service, and collaboration is a way of doing this work. This is how it all comes together. Again, these are components of ROSC, that we come together as people, as providers, as a system, and ending up where we always end up, which is in community. Now, I want to share with you what ROSC is not. It's not a model. This may confuse a few of you. It's not primarily focused on the integration of peers and other recovery support services. It is not a new initiative. It is not a closed network of services and supports. It's not a group of providers or community stakeholders that increase their collaboration to improve coordination. And it is not an infusion of evidence-based practices. And it is not an organizational entity. Let that kind of sit with you for a moment. Did you think that any of these here were actually ROSC? So I'm now going to shift to share with you what we believe ROSC is. It is a values-driven, equity-focused approach to structuring a behavioral health system. It provides and promotes the range of services and supports and opportunities in communities that all people, not just some people, not just people affected and impacted by addiction, all people need to protect and sustain their wellness. And those with behavioral health conditions need to initiate their recovery to live meaningful, fulfilled, connected lives. Now, this is probably the closest I've ever gotten to the clearest understanding of ROSC. So I'd like you to pay attention here. ROSC is a network of clinical and non-clinical services and supports developed and mobilized to sustain long-term community-based recovery. That is its end goal, long-term community-based recovery. No matter how many treatment programs we've been in, no matter how many residential programs, detoxes, clinical services, we always end up in the same place. In the end, we're in community. That's where we need to pay the most attention because that's where we all end up. Developing a successful network entails aligning, very important, aligning many aspects of a service system and community with a recovery-oriented approach. So this includes treatment, peers, other services, system monitoring, performance improvement and evaluation strategies, prevention, early intervention, cross-system collaborations. And this is incredibly important, fiscal policy and regulatory environments. Now, I've been in staff retreats where I brought up ROSC and our financial manager said, well, if you're going to do that right now, I have some emails I need to attend to. And I was like, no, you need to be here because fiscal policy and regulatory environments impact ROSC. It determines where it goes. It needs to be aligned. And so everyone needs to be educated on ROSC. So all of these elements have to be aligned with a recovery-oriented approach. And this doesn't just happen from like what I'm reading. It actually is sitting for hours with those that are most impact, all the stakeholders, to create a strong, sustainable ROSC. Now, because ROSC are local and organic, a ROSC can't be implemented in one place and then picked up and copied elsewhere. These systems are as unique as the communities that formed them. So an organization can't have a ROSC or be a ROSC. It can only participate in a ROSC. I'm going to repeat that. An organization can't have a ROSC or be a ROSC. It can only participate in a ROSC. This is a system. So being that I'm an OD person, organizational development person, I could not do this presentation without at least mentioning the conditions of system change. Now, I'm not going to go into them at depth, but I wanted you to at least look at it. You don't do systems change without policies or practices, resource flows. That talks about money, finances, relationships and connections, power dynamics, one of my favorites, and mental models. We are talking about doing a paradigm shift of the way we've always thought of and understood how to take care of people and communities that are impacted by substance addiction. There's a structural change, a relational change, and a transformative change. So I also did some deep dives with AI around the current state of ROSC and parts of global networks. And in doing this work, I put together this chart. Now, you will have a copy of all of this so that you will be familiar with what I came up with. I'm sure if we did an even deeper dive, I'd get all the names of programs. But I think it's really important to understand that there is some great work going on around the country. And we had the opportunity to learn from each other and collaborate with each other. There are programs going out that are training and educating leaders. There are staff members throughout many different countries, and here are also regions, South Africa and Southeast Asia, who are doing some incredible work. Peer outreach workers trainings. They have recovery colleges in the United Kingdom, and they have program called Change, Grow, Live. In Spain, there is recovery language emphasized in public campaigns, Seamos Humanos, we are human. So there's an enormous amount of work and funding, funds, finances, budgets, money, focusing in on recovery in many different countries. We can't do this without there being a recovery support system. And so, again, we are looking at embedding recovery language. That takes education to do that and supports to be able to do this moving forward. It is really important for us to understand why we have to foster local recovery focused initiatives. So there should at least be 2 or 3, 4 initiatives, activities going on throughout your community, your country, your states, your cities that are focused on those initiatives. We need to maintain relationships with our coalitions and task forces. We need to coordinate with other recovery community organizations that are peer run and managed. We need to support organizations that are providing recovery services. We need to promote the adoption of peer services and support provider readiness. So again, a lot of this has to do with education so that we can make informed decisions moving forward to create a vision for everyone of what ROSC is and how to better do that, to contribute to setting standards and sharing best practices. And so that's something that we all need to do in working together. There is a power of peer recovery support services. You know, peers in recovery, we need ongoing monitoring and recovery management to support continued remission. We need to promote long-term recovery. You know, when I came into recovery, you came out of a residential treatment program and you were basically told to go to a mutual self-help program, which I did. And then that was it. You know, nobody ever followed me up, nobody ever see how I was doing. That's how it went. And today we look at it differently. We really are focused in on what long-term recovery means and engaging individuals. The power of recovery support services, it rebuilds lives, new networks, and new hope, and it prevents the revolving door. So really important. In fact, we have a saying that our peer recovery support centers are one-stop shopping because you can get an education, you can find a job, you can make new friends, you can get support for when difficult times happen in your life. We share weddings, we share births, we share all the deaths that have happened. You know, we as a result of the opioid epidemic and the drugs that are out there today. And we're able to support each other through that, especially through our recovery support organizations. And with this, I'd like to share a video with you that I produced about 3 years ago. And with the peers that I worked with, who I trained to be recovery coaches and to become recovery trainers, in which we trained an entire state of Massachusetts to understand recovery-oriented systems of care and to become recovery coaches. And so I'm going to pass this over to Kwaijo to share the video with you.
It was about 90 days into my recovery, early recovery. And I remember, my birthday's like right after New Year's, and I was craving. And I remember calling somebody from the group, and they came to get me, and they got coffee. And we ended up like talking all night, and my craving went away.
When you're at a place and you feel like you're there and you're chilling, and all of a sudden there's a DEA raid, you might be in the wrong room.
And so I struggled with it for probably 2 decades before I got into recovery.
And the night that I got arrested, I was working on my 8th day without sleep. I was strung out.
It's a disease. We have a problem with our brain. When I used to do drugs, my decisions were made for me. I'm not that person. That doesn't define me. And that's the same thing with the people that we work with.
We've trained over 6,000 people in the state of Massachusetts.
As a recovery coach, it's not that what I do for them, it's what I help them do for themselves.
My role as a coach isn't to make you do anything. It isn't to tell you which way to go. It's to create space and walk with you while you make your own choices.
Historically, clinical services were really about sort of kind of working with the person individually and really looking at their clinical needs. We didn't look at individuals holistically.
It's holistic. And this is the thing that I don't think we really truly understand. What works for me don't mean it's going to work for somebody else. And in recovery, you got to find what's the niche that works for you.
It may be self-help. It may be faith-based. It could be meditation.
That's what it is. Like I found the spiritual is what makes me and defines me. So I continue to do that. But I'm available to whatever other people want to do for their recovery.
BSAS is doing a great job now. A lot of the pushes towards recovery-oriented systems of care, which is ROSC, if anyone's heard of it.
ROSC.
The concept there is to have the entire systems oriented to an understanding of recovery.
It's about honoring the individual because your experience is not my experience.
It's difficult because you got to get everybody involved. The communities, the trainers, the doctors.
When you go to a dentist, the same thing, that they understand that you're in recovery, that they're not giving you medications that are going to put you at risk for relapse, that when you go for employment, that employer understands that you're in recovery.
They would make sure that self-care is implemented throughout my workday.
Wouldn't it be nice that people understand who you are, where you're coming from, and that you are in recovery? That way, people are in a better position and systems are in a better position to help you stay and sustain recovery in the long term.
Addiction is so shameful.
The stigma, people will look at us down.
We wouldn't help people for fear of how people would judge us.
Instead of calling someone an addict, call them a person with a substance use disorder.
Because when we understand that, we will then begin to understand how to engage with people in ways that are meaningful, in ways that bring people in and not further stigmatize people or racialize people.
So we're really excited about the new initiative for the Recovery Education Collaborative.
We chose the right people.
Bay State Community Services, C4 Innovations, Choice Recovery, MORE, which is a Massachusetts Organization for Addiction Recovery.
And then Torchlight Recovery, which is a recovery support center that I supported in creating, comes out of the Nation of Islam.
We've all come together to really take on and continue the amazing work that DPH has done.
We want organizations to recognize that the ones we serve, they need to be in decision-making positions.
Like, we need syringe access programs. We need safe consumption sites. We need as many harm reduction measures in place to save lives so people can get to recovery someday.
Recovery, you can't do it by yourself. You need people around you.
And someone can know and can understand that you too have been there, and you can speak to some of the things that they're going through.
You can see them open up. And I've had doctors tell me, I've been working with this person for X amount of time, and they've never opened up to me the way they open up to you. And that is the magic of peer-to-peer work. That is the magic that, having somebody with that lived experience, that actual lived experience, and not like from a book, from a textbook, it works. It absolutely works.
ESAS has done an amazing job developing the peer recovery supports. They have put time, energy, resources, blood, sweat, and tears into making sure that the peer recovery support centers have what they need to be able to provide these services.
Right now, we're integrating recovery coaches into many different settings, court settings, medical settings, treatment settings,
Hospitals in the pregnant and parenting department.
you name it.
I think the thing about recovery and sustained recovery is creating a life that's worth it.
I think at this point, it's pretty safe to say that we are the only state in the United States of America that will have 37 peer recovery support centers supported by our state government.
I think in our communities, we need to really focus on celebrating the joy of recovery, not what's happening when somebody is in active addiction.
Apologies to everyone for all these technological issues. So I hope you enjoyed the video, and I really truly miss my trainers as I retired recently. And so these are some of the Massachusetts peer recovery facilitators with lived experience. And over 10 years, we trained 7,000 people. At this point, there are at least over 2,000 are working as peer recovery coaches, and hundreds are certified addiction recovery coaches. Our theme, of course, is nothing about us without us. People wonder, well, how do you get peers involved? What are the love the things that you get peers to do? That they're very good at. They can do peer trainings. They can be on advisory boards. They can do outreach and recruitment. They can co-chair committees. They can coordinate events. And so there are many, many things that can be done. A community member, a peer with lived experience is a valuable resource. So we have to listen to them, treat them with respect, and compensate them for their future. I actually had some conversations in a meeting that I was in, where we were talking about how much should a peer recovery coach get paid. And so I was going for a certain number of dollars, and a leader within the organization said, wait a minute. My master's degree people don't get paid that amount of money. And I said, well, then you should advocate for them. I'm advocating for my people. You should advocate for yours. The fact is this: I have 18 years of addiction experience, and I have 40 years of recovery experience. I'd be very happy to exchange my 18 years of addiction experience for someone else's master's degree, but I don't think they'd be willing to do the same. I consider someone who has lived experience and has been in recovery to have a master's degree in addiction and recovery, and with that should be treated as such. Now, of course, we continue to educate people as we would any staff person, and enhance the skills and abilities and raise their responsibilities. And now we have directors of recovery support services in many of our different organizations in the state of Massachusetts. As a result, peers with lived experience working everywhere. As Hane Hernandez had said, we're everywhere. We're in insurance companies, private practice. We're in employee assistance programs. We're working in police departments. And certain police department here in the state of Massachusetts, they actually call our peer recovery coaches angels. So we're everywhere in prisons, in courts. And so the fact is, we do really, really well in representing and sharing our lived experience. And that impacts other people who are coming into recovery. Now, in moving toward a recovery-oriented system of care, so oriented values and principles should be included in funding requirements. Well, when I worked for the Bureau of Substance Addiction Services in Massachusetts, I realized in doing some of the trainings that they needed the recovery coaches, the people who were being trained, needed supervisors, and the present supervisors in their organizations were all clinicians. And we realized that we needed to train supervisors to supervise the peer lived experience workforce. And so we created a 3-day supervisor training specifically for working with peers. There was a lot of pushback from a lot of the the organizations, the nonprofit organizations, who said, well, we have supervisors that have been doing supervision for 10, 15, 20 years. They don't need to be trained. And so they came kicking and screaming because I ended up requiring, if they wanted to be paid for or reimbursed for peer recovery coaches that they were hiring, I required it in the request for funding proposals. I required that to get funded, they would need to have a supervisor that was trained in our curriculum. Again, a lot of pushback to that because people didn't understand the difference and the value. It wasn't until supervisors actually were in the training and at the end of the training it said, oh my God, I had no idea. I'm so happy and so grateful that I took this training. It truly helped me understand how I can use values and principles in supervising my peers. So also including participatory assessment of needs, assets, and strengths with all funding. This is not an easy thing to do. We had peers that were required at some point to sit in on funding evaluations. They would read proposals and we had a scoring system, and they would join a team and give their voice to particular scores that would then determine who got funded in our state. Over time, they were uninvited because it took too long. It was time consuming. They asked too many questions. They had to be trained on how to do the scoring. And the system just didn't have time for that. So the fact is this: doing ROSC, moving toward a recovery-oriented system of care, requires an enormous amount of patience and commitment on leadership's part to do all it takes, including take the time to ensure that the voices of families and peers are included in all that we do. We adopt long-term recovery measures as a metric for assessing effectiveness. That's the only way we can tell if our work is what we're doing is working. And I cannot emphasize this enough. All staff, including board members, need to be trained in principles and values and how to promote adoption of trauma-informed services. Board members are making incredibly difficult and important decisions for organizations, but they've never been trained on recovery principles, and it's not enough to have a person with an experience on a board. You need the entire membership to be trained, all staff, fiscal staff, maintenance staff, HR staff, development staff, all board members to be trained in recovery principles and how to promote and move forward a recovery oriented system of care. And last, I like talking about policy. A review by which to review a process by which to review and change policies to be recovery oriented. Again, this takes a major commitment, and this has to come from the board. It has to then trickle down through leadership and through your vice presidents, if you have them, your managers, your directors. Some people think that a recovery, they have a ROSC or they have a recovery oriented organization because they've hired peers, but they have no idea what principles are and or how they relate and or are they aligned with moving in towards recovery, being recovery oriented. So I challenge you, if you're leaders, to look at this and think about what does it take to do this and where is your commitment? Now, wherever we sit in the system, we have responsibility and leverage. I had to change the curriculum. I had to put criteria to the curriculums because people experience to become a recovery coach. And still actively we're not get stability in their lives before they actually take 5-day trainings. And in essence, after the 5 days of training, they had to take a total of 60 hours of training and 500 hours with a supervisor who had taken our training, 500 hours of practice before they can even apply to be certified and take the exam. So we were very careful about creating a quality workforce. And it took sometimes making unpopular decisions to move things forward with the policy and principles and values of moving ROSC. So think about this. What will you add or change when you return to your community or organization? Recovery language is incredibly important. Let's start using correct language that's recovery oriented. Are you going to change policies? Are you going to do recovery trainings? Are you going to hire peers? Are you going to adopt long-term recovery measures? Most importantly, will you be able to keep fidelity to the peer model and not fold under the pressure to do whatever is fiscally proper and or what makes people feel comfortable? This requires a true commitment. And this is the only way you can reach sustainability. I designed and created a curriculum called All Things Recovery. And people said, oh, this is the peers? And I said, no, it's for the world. So I want to thank Faces and Voices of Recovery and ISSUP for this wonderful opportunity. And I want to thank you all for hanging in there with all the technological issues that happened. And know that, we are doing the work we're doing out of compassion and love. And there's no better world than the chill world. Thank you so much. I'd like to now turn this back over to Jonathan and see if you have any questions. Oh, before I transfer it over very quickly, I've added 2 slides of resources. So very important that you know everything I've shared, where it came from, and some extra resources to help you move forward in ROSC.
Awesome. And you can stop sharing anytime, Julia. All right. So, Julia, thank you so much for that incredible, thoughtful, powerful presentation. And we have time for questions, and luckily we got some questions from several of the audience members. And this first one, I believe, is really important as somebody who not only is in recovery from an SUD, but has a family tree that is there is addiction and throughout my genealogy. From Dave and Tina James, why do recovery services still have a negative 1930s attitude to families who support their loved ones' recovery journey when modern training like craft and invitation to change is available to professionals? And they added, families can make a huge difference during the pre-contemplation and contemplation stages of their loved one's recovery, years before they enter treatment. Harm reduction isn't just about clean needles and naloxone. So I guess, how does ROSC fit in, or how do you feel about that family part of recovery, which for those people who have still have family in their lives can be very important?
But yeah, I think we're definitely underfunded and underfocused when it comes to families. In Massachusetts, we have a program called Learn to Cope, and it is run by family members who have been impacted by addiction and or who have lost loved ones to addiction. And so it was, again, peers, family members themselves that were mobilized themselves, and then started mobilizing other family members to start outreaching to family members who were impacted, and then providing them with a safe space to share and an opportunity to be educated. And they had family sessions, even in living rooms, in kitchens, to start helping folks understand that stigma does not does not help anyone. It actually hurts. And we lost people in recovery as a result of family members pressuring people who were trying to recover with medication. And as a result, the stigma of medication, family members were saying things to them like, well, you're not really like in recovery because you're still using drugs. And we've had ODs as a result of that. One of our doctors at Mass General Hospital actually wrote, she was pretty upset because one of her patients died as a result of family members pressuring. So I agree with you. There are programs out here, but there's so much more work that needs to be done around stigma. And that's why I think all community members, all board members, all staff, anyone and everyone who's walking around breathing needs to be educated and brought in on how do we provide a healthy community where someone can be taken care of within their own community and where family members can support each other. So I totally agree with you. There's so much more work that needs to be done.
Awesome. Great. Thank you for that answer, Julia. All right. Next question. And continue to submit questions. I'm getting a couple more that are coming through. And if I do not pronounce your name properly, I'm truly sorry about that. So the next question is from Cavell Lynch. How do you address the issue of stigma? In the UK, stigma is the biggest barrier to having a true ROSC.
Oh, I agree. I think that, and not just in UK. I mean, we did stigma campaigns here in Massachusetts, and we used people in recovery to do videos, to do TV commercials, and we had them on gigantic billboards. We did radio station work with them. So we tried for 3 years. My concern is, just like recovery, stigma is a lifelong education. It's something we need to commit to forever, not just a campaign, but something that we, it's like, going to the movies. Well, gee, that was nice. Now the movie is over. And so now we go home to our regular lives. It's the same thing with stigma campaigns. They will hit a certain population, but if we don't do consistent maintaining education and environments that are getting rid of stigma, educating people around stigma, we won't be able to ever get rid of it. Even the special populations. I worked with recovery community organizations, and people were saying, "Well, there are no LGBTQ communities coming into our centers." Well, hey, how about becoming friendly to that community and letting that community know that you're open? And so once some of our centers started putting out the pride flag and letting people know from the outside of the building, you are welcome here, then folks started coming in. Same thing with stigma. We need to let people know straight up, this will no longer be tolerated. You know, we are all human. We are all here to support each other. And when we reach those barriers, when those barriers come to play, we need to combat them ongoing forever and ever and ever. Campaigns should not be campaigns. They should be ongoing services moving forward to get rid of stigma.
Yeah, I completely agree. I know when I got into recovery back in 2016, stigma was really the talk of the town. It was we have to start really promoting people that are in recovery and getting that word out and stop being shameful. And I think that's a huge part of kind of reducing that stigma, using positive language or at least not negative language, and really talking to people, everyday people. And I'm proud to say that I'm a person in long-term recovery, and I say it loud and I say it proudly. And I think that's important for people who aren't in the spaces that we're in. Yeah. To say them in spaces that are not normally said in those spaces. So this is a great question, because I've heard this quite often, especially in peer recovery spaces, peer coaches, things of that nature. And this is from Jefferson Wambury. I've heard people saying using peer educators sometimes is not effective in prevention, since people think that they portray as role models. So when they have a reoccurrence, a relapse, then they may serve as a bad role model. What do you have to say about that?
Wow. Again, peer educators need to be educated as well to make sure that they are providing a quality education. But we also need to supervise our peer educators and to ensure that they are providing quality education. Now, that said, the enormous stigma that is attached to those of us who have lived through addiction um, is so overwhelming that it permeates everything. And it's easy for someone to say, well, that didn't work because, they were trained and educated and then they went and relapsed or they had a reoccurrence. Well, if you know anything about life, this is what happens in life. This is real life. And if you follow any of Bill White's work, he talks about reoccurrence and that it takes up to 5 years of being in recovery before I think it was, I can't remember the percentage, but it was a fairly large percentage that would finally reduce in terms of risk for relapse or reoccurrence. And so the first 5 years are very, very important in terms of getting full support. And, I say this all the time. Organizations need to oversee and support their peer workers. My co-chair of my consumer advisory board was in recovery via medication-assisted recovery for many years and was very successful. He was the regional coordinator for the Northeast when it came to medication-assisted treatment and recovery. And he was the co-chair of our consumer advisory board. To look at him, you didn't even know he was on medication. He retired after 20 years with the housing department and became a peer recovery coach as a sort of a side gig now that he was retired. And he started working in the street. And within a month, he died of an overdose. We were in absolute shock. In absolute shock. Our hearts broke in ways I can't even explain. And we were all like, what happened? What happened? Well, we realized we can't put people out there, no matter how many years they have, in the street, watching people shooting up, watching people using drugs, watching people nodding out, watching people, the suffering through what addiction does to you, and without another partner being there with them. We should never put a peer educator and or a peer recovery coach or out there by themselves. We are talking about people who come from lived experience with addiction. No matter how many years we have in recovery, we are vulnerable to the world and to life, just like anybody else is. So I think it's really important to recognize the fact that this is life. This is not, you were clean or in recovery or in some cases abstinent or you are in harm reduction for this much time and now you have, you know, had a reoccurrence. That means that what you did and what you've done and who you have become is no longer valuable. That's bonkers. And so it really, you need to understand. That's why family members don't go to family members. People in recovery don't go to their families. They create a new family that is not judgmental, that supports them no matter what, which was what families are supposed to do. But it's extremely difficult as families need much, much support too.
Yeah, thank you, Julia. I hearken that to, there's stigma outside of recovery spaces from people who don't know about recovery. Maybe they heard a little bit about, those 12-step mutual aid programs. And then there's stigma inside recovery spaces, which is what that kind of points to that, again, we're all human. We all, have our own little issues, and sometimes that happens, but that does not mean that that person is no longer a role model, and no longer helpful to the community that they are still a part of if they want to be a part of it. And it's really important. Next question from Raul Ayala. How might you most effectively introduce ROSC into federal treatment court programs?
That's a good one. I actually did a presentation for court judges and probation officers and lawyers about ROSC. It was pretty interesting, um, and they were like, "How do we do this in court?" This particular one was family court. I thought that was fairly easy. I don't know about federal court, but this one to me, very simply said, I said to them, well, what is your experience? And they talked about, well, the person comes in and what are they, a defendant? And we've taken their kids away because they were, using, and now they're back in court and we have to determine whether we are going to, reinstate their family. And so, we basically make these decisions as quickly as possible because we have a lot of people coming through. And I said, what would it take? What would it cost for you as a judge to actually treat the defendant as a participant? Actually treat them as a participant in their own recovery. Most people go to court and they depend on the judge to tell them what their future is going to look like. What if the judge asked the person treating them as a participant, not a defendant, and said, what do you think? Where are you at right now? Do you think you are able to take care of your kids right now? And it's okay if you say you're not, and we'll provide services for you until you can feel stabilized and with the idea of bringing back your family. So we're not talking about taking your family away forever, but providing an atmosphere in a courtroom that where people feel a certain amount of trust. How difficult is that to actually, and so there are judges that have created that atmosphere and that climate and that culture within their courtroom, but they're few and far between. We have had to educate judges on the power of peer recovery coaches, and we now have peer recovery coaches in several courthouses and courtrooms in the state of Massachusetts. And it took us showing up and showing them the value for them to now be advocates for us. And so we have had court judges on panels now who are advocating for peer recovery coaches and the support that they feel that they've received as a result of partnering with peer recovery coaches. So it takes time, effort, energy, working with the probation officers, working with the lawyers, but being in the courtroom is the first step. Actually physically being in the courtroom and working with them to form a partnership to then make some changes moving forward.
Yeah, I like that. They shouldn't be viewed as defendants, but participants. This is a disease. It's called a substance use disorder. Great way to put that, Julia. Let's see the next question, which is close to my heart. So what I do at Faces and Voices of Recovery is I run our recovery data platform. So we have a bunch of organizations all across the country that utilize to. Anyway, I won't get into it, but data is really important to me. And this kind of leads into, you talked about earlier, the 5-year kind of window where once you're over 5 years, there's a greater chance of you maintaining that long-term recovery. And that data comes from Dr. John Kelly, Recovery Research Institute. Look him up if you don't know about him. But a lot of his data comes from there, where he really sees after that 5-year period, the reoccurrence or the getting away from a recovery lifestyle basically almost goes. It's like I don't want to quote anything, but it's like 90% in that general vicinity. And before 5 years, it's of course lower than that. So John Winslow, has any data been collected in regard to the various recovery pathways and the number of folks engaged in recovery globally? Now, I guess I can answer this. I'll take from you, Julia. So recovery is it's a young system. It really is, as far as the systems that are needed to start collecting data. So I think in the future, when more data is collected, more long-term longitudinal data, we're really going to see how the recovery movement, how recovery in these individual organizations that are using ROSC, that are tracking different ways to recover from, medicated assisted treatment or 12-step recovery or natural recovery, the different recovery pathways that are all around us. So I think we're in the early stages of that data, but I'm looking forward to being a part of that long-term data in the future. So the next question is from Monica Barzanti. What about peers and people with lived experience providing drug use prevention to youngsters? Do you think they could be effective not only in the area of recovery? So this is looking at youth and drug use prevention.
Yeah, I don't. First of all, I want to thank you for bringing up John Kelly, who actually did the research and is doing fabulous work nationally in educating us with the data that he has gathered. In relationship to youth, I was the executive director of a nonprofit called Latino Entre Latino and the Sociedad Latina, and it was all about teenagers. And I had a group of teenagers which I worked with and educated to then go into the schools and into the community to educate people. And so we call them peer leaders at the time. I don't I'm not familiar with, the providing the drug medication to younger people. I'm not familiar with the data on that at the time. And again, I come from old school as much as I'd like to um as much as I am involved in multiple pathways of recovery and all the different kinds of pathways that there are. And I am an advocate for that. I don't know a whole lot about the reaction um, of young people, children, to medication assisted treatment and or to teenagers around that. So I'm going to have to defer to someone else when it comes to that. I do know that when I worked at Sociedad Latina, um, all the youth that I had were what we called at risk. And they came from homes where parents were using, where the some of the parents died from AIDS. This was way back, and we just built their resilience. We built them through their strengths. We guided their strengths and built that resilience so that they could then um, bridge their way through this world. And they became an incredibly strong group to be able to do that. Out of the 25 people, young people that I had, I believe the majority of them never ever used drugs. And the few that did went through what we all go through. Not necessarily addiction, but if you know prevention, is 3 levels before you even get to becoming addicted to alcohol and or other drugs. But it's something we need to put a lot more time and energy into. So thank you for the question. Sorry, I don't have a more specific answer for you.
No, that's okay. Yeah, the youth part of it, again, that's a burgeoning kind of thing in recovery spaces as well. To really that's where stigma starts a lot of the time. All right. Well, we have concluded this this webinar. Julia, again, thank you for helping us continue this series, which with such depth and heart. And thank you to the 190 plus participants that are here in attendance. Thank you all for being here and learning, and hopefully, educating others that you come in contact with. As we've heard today, recovery support is community-based. It is shaped by personal experience, culture, access, and community support. As we continue this journey together, we invite you to reflect on how your work can honor and uplift those affected by substance use disorder. So, in the next 48 hours or so, you'll receive a follow-up email with the webinar recording, the slides, and additional resources. And please also take a moment to complete the short feedback survey. We'd love your thoughts. And in closing, we'll see you again, hopefully in 2 weeks at the same time, same date, well, 2 weeks from now, as we start our advocacy phase. So the next one is returning to basics, successfully advocacy 101. Until then, thank you again and take care.
Bye-bye.